Hello, everyone, and welcome to our September 2025 Q&A. Eventually, we got here. Awesome. Michelle, we're gonna go ahead and take away your video because I'm not sure you want us to have you on video. Scott, you got her? Okay. Question number one: are aid services mandatory for certified home health agencies? Is this something that must be reported under the new COP, patient accepted to service? Acceptance to service.
Do you want to take that one, Sherry, or you want me to?
Well, you can start, and I'll bounce off of you if that's okay.
Okay. We have to remember that the 6 fundamental services for the Medicare Part A home health benefits, skilled nursing, PT, OT, ST, medical social work, and home health aid, are all to be provided to the patient when they meet qualifying and coverage criteria. So that's a long-winded version of, if you want to boil it down to, is having an aid mandatory? Technically speaking, yes. If the patient or the beneficiary is entitled to it, we are compelled to provide it, which means we should have it. But what do we do in situations where we may not have aid services? We don't have the staff. There's a variety of things that may have factored into that. We see it sometimes when an agency is unable to have a speech language pathologist either directly or under contract, or is struggling to fill the role of medical social work. Those are very real situations. The second part of the question is the crux of it, is that we have to disclose that we are unable to provide a certain service. So historically, what I've seen is that was occurring well before the change to the COP and this whole formal thing about disclosure of what you have or don't have. But historically, I think that was pretty clear when it came to things like speech or medical social work. Aid has kind of been a little bit different. And if any of you are new to our Q&A cycle, we are professional, but we can be a little bit more candid here than necessarily in a formal presentation situation. There's times I get nervous about when I'm hearing agencies say, well, we just don't provide aid. Like, it really isn't about the staffing situation. It's kind of we don't provide it, and our competitors don't provide it either. Okay, again, that's a choice, just like we could make a choice that we're not going to take wound care patients. But that doesn't change the fact that if the beneficiary is under our care and does qualify for the services of an aid, we have to disclose up front that we don't have it. And if they do insist they need it, we do need to find them another provider. Your thought, Sherry? You're muted, Sherry.
Apparently, my mic is picking up everything today, too, so I apologize for being muted in between. Cindy, I'm with you. I think the whole point of the new COP was them making it a condition of participation, and going to that level was the bait and switch kind of situation. And Cindy and I have literally met agencies that, like she said, that are in areas where they say, well, nobody provides an aid, so we don't. The fact is, patients need aid services often, and that is part of our offerings in home health, and technically is paid for in home health. What we don't want to see, and what I think CMS is aware of and don't want to see much more of, is that folks are not getting the aid services from the Medicare certified home health agents, but they're also doing a self-referral or referral for benefit to an outside aid service company. And that's the scary thing. We actually saw that in real life, and literally spoke to one of the private duty service business owners. And she told us that she was getting her business from certified agencies because they preferred not to provide the aid services.
Okay, let's see. Yes.
Okay, so I see you're not about Dr. David Christensen and
Hi.
Dr. Michael Christensen contacted the
Hello, Tracy.
the attachment under face sheet.
Mm-hmm.
Can you?
Okay, I was able to mute Tracy.
Okay.
You have to make me an admin if you right click my
Okay,
name.
I'm gonna turn you into a host, Scott, because that's
Okay.
crazy.
So while you do that, I think that that really is the crux of the issue, is that there's concerns that aid utilization, and I've been in this space for 3 decades now. And I remember when I started, aids were like an everyday to the visit to the patient because it was still under, basically pay per visit. And there would be signs up in the summer, things like, it's getting hotter, increase the aid. So it's a little bit of whiplash to go from that, which I'm not saying was the right way to do it. There definitely were concerns about overutilization at that point. But now it's really difficult when I audit charts and it's like, so you even ordered occupational therapy and you're talking about how this patient has multiple issues with self-care. They live alone. OT seeing them once, maybe twice a week, which is a whole other conversation. And then there's no home health aide. I think the other key piece we have to keep in mind, and I'm going to use an ALF example here, because I will often hear the justification is, well, the person lives in an assisted living environment. They're paying for an aide already from the facility. I don't have to offer them one. That's already taken care of. They don't want my aide. Okay, that may be the case. You may talk to the patient and the patient says, no, I don't want that. I'm comfortable with the aid that I have. That's fine. That's their choice. But that needs to be documented. We need to be documenting that it was offered to the patient and they declined, and there's the reason for our own protection, because then it makes it explicitly clear I did not withhold the aid in an ALF situation to control my cost. I did what I was supposed to do, is they qualify it under the Part A benefit. I presented it, they declined it. Okay, fine, we're all good. They can do that, but we have to make sure the documentation is there. And overwhelmingly, when I hear, yeah, but they're in an ALF, I never find that in the documentation that it was offered and refused.
That's the scary thing about it, is that when we start changing those offerings and decreasing what we're giving the beneficiary, any of that is risky. But to do it specifically with the aid services, and literally the guidelines for aid services, if you look at Chapter 7, it says that the guidelines for the aid services are up to 25 hours a week, or in that neighborhood, okay? Which all of us just go and clutch our pearls when we hear that number, because that's a ton of time and a ton of dollar going to aid services. But we need to give the patients what they need, not what they want, what they need, and what's going to change their medical situation. So remember that these are medical aid services and not housekeeping aid services. Cindy, can you just talk to that for a second?
Well, we do need to keep it within the scope of what's under the Medicare Part A benefit. And there is sometimes confusion that an aide is going to, clean my house and do other housekeeping related things. I mean, I think the other piece that often gets overlooked is that the aide can very much be an extension of the therapy services in terms of helping follow up on an exercise program, reinforcing certain things related to positioning or specific techniques used to manage their ADL challenges. So it really isn't just, I think it swings both ways. Sometimes it's, well, they're supposed to do everything in the kitchen sink, which is technically not correct. But other times I think they're very pigeonholed into they only do these few things when there are different ways we could be utilizing them. And a question came in recently, Sherry, it was not added to the list, but I get it pretty often when you start talking about maintenance therapy. And especially when you're talking under the condition where, I'm overseeing this program, it's focusing on stabilization of function, someone else is executing the program. So they don't need the skills of a therapist to execute, but I am overseeing, updating, modifying, ensuring it's effective, all that good stuff. There is sometimes a concern that, okay, wait a minute, if we do this, then we're going to have LUPAs. Because if the therapist is going that infrequently, then we're going to end up with an increase in our LUPAs, and we're trying not to do that. My common response to that is, you do understand that a patient receiving maintenance therapy also would qualify for an aid as appropriate. So I'm not suggesting that we're saying, if I'm worried about LUPAs, I'm just going to give everybody aid again. But I think there's times we miss appropriate opportunities to say that in this case, when there is low utilization expected from nursing or from therapy, is an aid an appropriate addition to this program, and could it ultimately then help us avoid the LUPA situation?
Because that is ultimately part of our goal, right? Is to make sure that we're going to get paid exactly what we need to get paid to take care of the beneficiary the way they're supposed to be taken. But I want you to know by making this a COP, I'm just going to warn everybody, that means it's on the it's on the payer's radar for something they're going to be looking for. So this one was, we put it first because it's super important that you understand that the auditors and the surveyors that are coming into your agency may be specifically looking for your aid processes and your aid visits. And again, I'm just going to echo what Cindy said. If, say you have a wound that needs to heal and it's an unclean environment, but your patient only accesses the living room and the bathroom and the bedroom, the aide is really only responsible for making sure that the living room, the bathroom, and the bedroom are hygienic enough to assist with healing of that wound. So it wouldn't be a full clean. It might be a moving of things out of the way. It could be a number of different things, but you want to look at it from that medical lens and what the patient needs. So Cindy, do you have any further thoughts before we let this one die the death it probably deserves? Okay.
You've muted, Sherry.
Question number 2 is, can you tell me exactly what is changing for Oasis E2? When is the implementation date? I heard 4/1/25, but that seems strange.
Well, that is strange. We saw some information in the proposed rule, and at the time we're doing this today, we're still in proposed rule limbo. A final rule generally drops in October, so we'll see if anything changes related to this. I'm highly doubtful anything OASIS specific is going to change. I think the bulk of the discussion around the proposed rule was everyone's collective anxiety about that kind of a looming pay cut. I don't think there was a lot of feedback about the OASIS, but it is important that we keep it in mind. But it stood out to me to say that, well, what we're going to do is X, but it's not going to go live until April 1st of 2026. I kind of think, well, that's almost mean, almost like an April Fool's joke. Did you pick April Fool's Day on purpose? For years, I've said, it's almost mean to home health that our OASIS changes always happen on January 1, because we know that trying to prepare staff for anything that changes in OASIS is typically something we have to do fairly last minute. You're not going to teach them 6 months ahead of time about something new in OASIS because they'll forget it by the time they got to do it. And then the window just ahead of it, when it's January 1, is the major holiday season, which has always been a challenge. So there's some positives, I think, to April 1st being that, because now we can use March for training and have much less competing issues than we typically do when it's December. But the numbers changing. So we didn't see the alphabetic letter change. We do see a number change, and sometimes that sparks okay, how many changes did they really make? OASIS, not that I am. I went through all of those and looked at it, and a couple things. One, I'm kind of frustrated with the number of times that the proposed rule referenced that they removed 4 OASIS questions. Because I'm like, wait a minute, what do you removed? What did you remove? So you go dig in there and you go, oh, hold up. They are removing one. The COVID-19 question is being removed, but then they referenced others. And long story short, I'm sure I'm not the only one who noticed, the ones they're saying they removed are ones that they're simply choosing not to implement. So ones that we were told in 2024 would go live 26 are being diverted. So it really isn't a win in my mind. If you didn't add them, you didn't remove them. And if we've never filled them out, you're not really saving us any time. So the word choice of removing is a bit odd to me. Some of the feedback I've heard about removal of the COVID-19 is almost, well, it reinforces something I was concerned about when the question was implemented. I'm hearing some folks say that they feel relieved to a certain extent that that question is coming out because of some of the tension around even bringing that up, from the admitting clinician to the patient at the time of that initial assessment. And when I first saw the question and did teaching around it, getting people ready for it, I went kind of outside the manual and said, you might want to kind of anticipate that there could be some issues with this. Folks being uncomfortable asking the question or getting annoyed that you asked the patient the question. And apparently that did bear out to a certain extent. So it's going to be gone. The awkward part about that, Sherry, is what I'm hearing, and others can chime in that box if it's you've heard something different. But it appears that when the final rule drops, the confirmation of the removal of COVID-19 data means that from that point forward, they are not going to use the response to that question anymore. So that reads like October would be the end, technical end of them utilizing that COVID-19 question, but it will not leave the form until April 1st. So that's going to be interesting to kind of see if vendors are going to leave it alone, what they're going to do with that. I guess, I mean, I've heard some people say, well, that just means you can put whatever you want in there because nobody's going to analyze it. And I'm like, okay, that seems a bit of a free-for-all, but that remains to be seen. Other things are really not earth-shattering things. They're going to be updating the language of the transportation question. Yay! I am so happy about that, probably sadly so, because there was such a disconnect between the guidance manual telling you the last 6 months to a year, and yet that language not appearing in the question. So in working with clinicians and doing our OASIS knowledge assessments and such, that was a big sticking point where it didn't seem that the data collector was remembering to say the time frame or understood that there was a specific time frame. I got all kinds of, prior to this illness or injury, in the last month, before they went in the hospital, and that is not what the guidance said at all. So putting that kind of time frame in the question, I think, is really going to boost accuracy and consistency with that question. A couple others are getting just some wording changes. So I don't think it's going to be catastrophic, anywhere near what we've seen in big changes before, but it is something you're going to want to kind of put on your 2026 end of Q1. Okay, what is our plan, just to kind of revisit it? I also think when the changes aren't that substantive, it's also a good time to start looking at March and say, what are some of those OASIS questions that are kind of making our auditors and reviewers want to pull their hair out? Or what are the ones that are coming to me and saying, oh my gosh, this question or these couple questions keep getting missed? That could also be a very good time to add that as a reminder as part of the E2 piece, because you're going to have to get their attention anyway, to strategically use it to try to get rid of some longer standing problems at the same time. But overall, I mean, it's a number change, but it's not, I wouldn't say anywhere near some of the biggest. It's just kind of clunky with the COVID-19 piece and then moving implementation to April 1st, which is highly unusual for us.
Very unusual and interesting that they're doing it that way, but there's a lot of interesting things happening right now, and that's one of the things that I would look to the next round of OASIS Q&As to see what you should do from January to the end of March. And if you have that question, please submit it to the OASIS Q&As. I think it's a very valid question to say, how are we supposed to handle this if our EMR adds those questions on January 1st, like the plan was, because it's sort of a limbo 3 months, right, Cindy?
Yeah, but I would also say, it's also time to, there might be agencies out there that say, okay, maybe CMS doesn't want that anymore, but I was using that information as part of infection control or something else. You can elect to keep it. And you can even elect to keep it past April 1st, and all they would have to do is remove the lead-in alphanumeric piece that identifies an OASIS question. I've seen that happen in the past when there's like, well, this is an important piece of information for me. CMS doesn't want it anymore, but I still do. Can I still have this in my EMR and track and trend those kinds of things? You absolutely can. This decision doesn't forbid you from collecting COVID-19 information. It's just that they don't want to use it anymore.
Exactly. And next question was actually submitted by someone on the session today. Are we ready?
Yep.
Had discussion today regarding Min Assist for the GGs. Is that considered O4 supervision / touch assist or O3 partial / mod assist? Thank you, Lynn, for that question.
Well, my guess, Lynn, is a therapist was involved in this discussion either directly or indirectly. Because I think it's always been the how do we match up clinical with OASIS data collection? And we know that the 1800s are way off of that. That they lump all assistants together. That's been a decades long trying to get people to understand that. The GGs broke it out into something that sometimes looks and feels a bit more clinical. But we have to keep in mind, it is discipline neutral data collection. So whereas a therapist will say, we've got all kinds of levels of assistance. We got supervision, we've got contact guard, we've got standby assistance, we've got min, mod, max. When we look at how the GGs break it up, when we're talking about O4, supervision or touching, it clarifies that that is literally either I have not touched you, but I am supervising you. So that would encompass a therapist documenting supervision. It would also take care of standby assistance. And by virtue of touching, it would encompass contact guard assistance. So that is just for folks' own edification today, that is basically that steadying touch. I'm not lifting, I'm not supporting with any sort of significance. I'm putting a hand on you for steadying purposes. That fits under 4. When we start talking about 3, and by extension response 2, the big difference between mid, mod, max and those two responses is those two responses take the whole level of physical assistance and cut it by 50%. So either the person is providing less than 50% or more than 50%. So by definition, minimal is I'm not just steadying you, I am more physically involved. Minimal would fall more under that issue of response 3, partial moderate. Okay. But this is where sometimes when I audit records and I talk to agencies, they try to take a therapist saying moderate and make it moderate here. That's where we get into trouble because mid, mod, max does not match up with a 50-50 split. So it takes
Cindy, I have to say this right here. The words touching assist or touch assist have become a new ick for me.
Oh yeah.
As a physical therapist assistant and athletic trainer, it just sounds gross. Is it just me?
Well, no, I think it's to me, I like to use it in working with clinicians, regardless of discipline, as another piece of evidence that OASIS is discipline neutral data collection, because nobody would take that term and start using it in their clinical notes. I mean, if I started documenting, I'm patients doing this activity with touching assistance, you're right, there'd be an ick factor of what exactly do you mean by that? Because that's kind of weird. They tried to use that term, again, in a neutral way, but it does help to center us that these are not identically matching up to any sort of therapy tiers. There's some relationship, but I believe the mid, mod, max has been the most confusing. Mid, yes, I absolutely agree. That's a response 3. Max, yes, you're looking down at response 4. But if the clinician is documenting moderate, there needs to be some additional conversation about, are you talking about less than 50% or more than 50%? Because if it's more, yep, I technically can call it moderate as a therapist, but more than 50% would actually be response 2 and not response 3. And don't forget the wild card. If it's 2 people involved, even if 2 people are required to provide supervision, or one's doing supervision and the other one's providing touching assistance, then the correct response is dependent response 1. And that's where I still believe we are grossly underreporting because we're not following the directions, because we're trying to make that clinical. And clinical, if this person is, basically a deadlift, we know that, how that all works with other functional questions. But GG has said from day 1, if it requires 2 people, that doesn't mean a 2-person deadlift. If one person is helping and the other one's supervising, if 2 people need there to be supervising, and that's what it takes for them to be safe, then we're supposed to be scoring them response 01 dependent. And I think that's something we haven't quite done the best job of. And again, many people know I'm not into this to game. That is not a secret tip to use dependent and make your outcomes better and whatever, value-based purchasing. But I think that's a situation where we have not done the best job of helping clinicians understand that if it's 2 people in any capacity, then you're supposed to be putting response 1.
And Cindy, I put up our next slide because, when anytime you get anything free in life, there always comes a little advertisement with it. And we like to use our advertisements in a way that seem genuine. And that particular question, thank you again, Lynn, is a great example of something that you wouldn't know is being answered incorrectly unless you queried your clinicians or you queried your review staff about how often folks are getting that wrong or right. And so one of the things that our testing does is it allows you to know where your clinicians are and in relation to where you think they are, and then enable you to focus your education accordingly. Cindy, do you want to say anything about our testing and our assessments?
I can boil it down to this. I think we've all, at some point in our home health career, been in an educational session, either in an agency or at some conference, and you've sat there going, why am I here?
Mhm.
I already know this. Why am I here? Or you're now in a leadership position or decision-making position, and here we got to educate for E2. Does that mean we're hauling everybody in? Because that can get very expensive. It causes scheduling problems. So our goal with testing is simply to help weed out who needs education and who doesn't, and what do they actually need to be educated on. I think we try to figure it out now by virtue of the corrections process, but that has other issues associated with it in terms of we're trying to get this reviewed, we're trying to get it out the door, the reviewer sends it back, and we have agreement with corrections, and the dance continues. By looking at it through a testing lens, the goal is to help figure out what those educational needs are. And is it really something a whole bunch of people don't understand? Let's make that a teachable moment. Or do I have a couple of clinicians that are struggling that I need to spend some more time with and not bring everybody in for this training?
Exactly. And to keep everybody focused when they come in for that training, if you give them the results of a test that they took and say, these questions seem to be a problem area, here's the education, here's the ability to get to an online link or an online tutorial for that item, they're going to be a lot more receptive than saying, this is going to take you 2 or 3 hours to
Right.
take care of this. And then you're going to have to retest on it. And guess what? Next year, you're going to do the same exact training. That's crazy time for clinicians, as y'all know. So Cindy, next question. Are you ready?
Yep.
Okay, this is another hot button one. It's interesting the questions that we got this time. It is, our agency is seeing therapy frequencies of 1 visit per week on a regular basis. For some therapists, this is what they recommend for the majority of their patients. Should we be concerned about that?
Well, I think we just need to step back a minute and think about therapy provision in other settings, or maybe therapy you may have personally experienced. When we're talking about rehabilitation, this really comes down to that the interactions with therapy, that time with a skilled therapist needs to be dosed appropriately. That's a term I choose to use because I think we need to take our patient encounters that seriously. So whether it's a nurse or a therapist, I'm recommending the dose of my particular discipline when I write down my frequency. And so when we think about ourselves or maybe a family member that's gone to outpatient therapy, particularly when therapy starts with a patient, we tend to see a higher frequency at the beginning, 2 times a week, 3 times a week, typical coming from outpatient. Clearly, if somebody is in a rehabilitation situation, in a rehabilitation unit, clearly by its name alone and its designation, we fully anticipate that this patient is going to have therapy on a daily basis. And for inpatient rehab, they have to be able to tolerate a minimum of 3 hours of therapy a day in order to be there. When we think about a skilled nursing facility, we do expect a higher intensity of therapy. We're saying that, well, they're in this facility for a reason. They have a higher acuity of problem. Therefore, I would expect to see a higher intensity. So that leads us to home care. Out of the gate at 1 time a week does seem a bit low, especially when we look at our history. So I don't think we were ever in that arena of the home health aide of, send them every day prior to PPS, or the, yay, we got BID nursing orders. That was our history before they put us on the PPS prospective payment budget. But therapy has typically been coming out of the gate at 2 and 3 times a week. And through that whole time prior to PDGM, I spent a lot of time talking to therapists about that very first week. So if we have a higher acuity patient with much more complex functional and self-care issues, should we not even consider in specific patient situations to go daily? Or at least coordinate. If we're going to have PT and OT, can we work the schedule that they're getting it, a therapist is interacting with them on a daily basis initially. We can taper down from there. And there was a more openness to that discussion at the time when therapy visits affected reimbursement. Since PDGM, it looks like it swung the other way. And not just to me, but if you looked at not just the proposed rule for 26, but 25 and 24, CMS has noticed this as well, that utilization of therapy dipped. And we could absolutely argue that the timing of PDGM and the pandemic was way too close together, and it really messed with data for a period of time. But if you look at that same trajectory, nursing visits have been rebounding, therapy visits have not. And so why am I going there? Because I think it's already on the radar from CMS that utilization, okay, if you're now telling us that historically you needed this much therapy, and so we built PDGM on that, and now you're telling me they don't need this much therapy, I'm going to believe you, but then I'm going to cut your rates because I built your rates on your historical therapy use. And if it's really now you're telling me it's not like that anymore, they really only need this much, then logically and not meanly, I'm not going to pay you for services you're not providing at that intensity anymore. And so, yes, we can argue we end up in a cycle of they cut our pay, we have to manage visits better, they cut our pay, yet that's a whole other thing. But to look at it and say, now PT's only going to go once a week, OT's only going to go once a week from the jump. Or still, well, you can't go at the same time, so we're going to give physical therapy first and occupational therapy later. We really need to rethink those strategies because what we're ultimately trying to show is we are doing what the beneficiary needs, not excessively, but not under providing. Now, I will say, Sherry, there are situations, and I've been in them as a PT, where I go out there and I really believe this person should be seen, let's say 3 times a week. And the patient is giving me the whole, I'm overwhelmed, I got too many of you people coming in my house. I got the nurse, I got the OT, I'm sick, I'm tired, I don't want this. Okay, I can't go kick their door in. But you better believe I'm going to be documenting that my recommendation was 3 times, and we're going to be doing 1 time because the patient is refusing more than that. Because I'm also going to clarify that this is going to have an anticipated effect on my plan of care. We will probably not progress as rapidly. We may have additional setbacks and issues because this intensity is lower than what I believe this patient really requires. So if this really is about, but the patients are overwhelmed and don't want this, I respect that. But then we should be documenting our professional opinion against the reality, because if I don't put that in there and I just write down 1 week 1, 1 week 4, whatever, then the assumption is that I, as the skilled professional, dosed myself at once a week. Now, there are patients that are coming to us after they've been in a SNF, they've been in an IRF, whatever, and they've had therapy. Or my personal favorite is they got their knee done. Yeah, they got the other knee done like 6-9 months ago. They know all the exercises. They know all the things that they have to be doing. They're totally on top of it. They've already lived through it. Yeah, then maybe once a week is what I'm going to put just to be on the safe side and ensure that they're going to progress at the rate that they anticipate they are. So there are situations where it makes sense. When it starts to become, and I've done some therapy audits recently where I ask for 10 random charts and 9 of them, the therapy's all at 1 time a week from the jump, I do have concerns. And I think we need to look at this and say, what are we going to accomplish at 1 time a week? Are you really able to demonstrate the impact of this care? Is this really matching the complexity of the beneficiary's needs that you've also documented?
That's the thing, right? You have to make sure that you're matching what the beneficiary needs, and it needs to be individualized to that beneficiary. So I'm going to warn you that any time you have a consistent use of frequency over a number of patients, that would need to be changed because it really should be individualized to the needs of that patient. Cindy, what do you say about the clinicians that are pushing back against this because they're being told they only can offer so many visits?
Well,
Well,
um, and yes, this tends to be coming to the forefront now around therapy. But I felt this way before PDGM when I would see a whole bunch of 1 week 9 coming from nursing, which is really what we have to defend ultimately in our documentation is why you, why now. So if you have a clear vision for this patient that your 1 time a week is going to accomplish these particular things in light of your assessment, and they absolutely positively don't need more, so be it. But I think what clinicians struggle with is top-down pressure that says, I'm sorry, you only get 3 visits, or you only get 5 visits. And I think therapy is going through the transition that nursing did in early 2000 when we got off the per visit train and went to PPS, and it went from no more BID to why are you still in there? You've had a few decades to work through this. I think what's happening to therapy now is wait a minute, so if I did 14 before, you were fine with it, and now you tell me I get 3? I think there needs to be some healthy conversation about the needs of the patient, and ultimately, those orders have my name on it as the practitioner, and by extension, my license. So the whole, I can't do anything about this, I can only do the number that they tell me, can be a slippery slope. Because ultimately, coming back and looking at the clinical decision making, the person who signed it and wrote the plan and did the visits is the one considered responsible. And so I understand the need to look at utilization management, but it's now a term, Sherry, that makes my eye twitch when it becomes a dictatorship. We've looked at this person's amount of money, you only get this amount, and that's it. PDGM is no different from PPS in one fundamental way. They know it's not perfect math. They know there are certain times the math is bad and we are going to lose money on a patient. And we also know there's times the math is weird and somehow we got more money than we need to take care of this patient. This is supposed to be about net gain and net loss. This was PDGM, no different than PPS, did not put individual patients on their own budget. So yes, we need to be aware of it, but when it starts slipping into, I've done this math, that means you only get this amount and we're never going over that because we can't do this. We run some risks in terms of providing the appropriate level of care to that patient.
and
So
Cindy,
we should go to another question, Sherry, because you could get me riled up for the next 2 hours. And I know folks have submitted other questions we need to get to today.
well, I do want to add one caveat because I have a caveat when it comes to the word visit. The word visit could be old school, and we need to start thinking about patient encounters and not just going out and seeing the patient in person. We are coming up on a deadline of September 30th where telehealth is going to be out of our ability due to some legislative changes. And I heard there might be a government shutdown. Anyway, it's a lot of chaos. So it's a possibility that we're going to lose the telehealth protections that we had during COVID that have been used so well in home health, probably not to the level they should be. But we do a lot for patients that is outside of a physical visit. And physical visits are the most expensive thing we do because it includes mileage, it includes time out of patient. It's expensive to go out to a house. So start considering having a way to document encounters outside of visits that may take place of visits. So your frequency might be 2-3 times a week. But if the third time you're waiting on a piece of equipment, that would be a real reason to miss a visit, that you put that visit on pause, that you're waiting for that equipment after you spoke with the patient. Those kinds of conversations and those kinds of encounters really matter, and they matter in the outcomes of our patients. So we need to make sure we're doing a great job of documenting that and rounding out all the encounters that your agency is having with the patient. Because I guarantee you, if the nurse is writing 1 week 9 and the therapist is writing 1 week 9, are you only having 2 encounters with that patient that week? Do you think that is possible, Cindy?
Unfortunately, I do think it could be, but I also agree with you that the phone calls, the follow-up, the reminder, those interactions with the patient need to be documented. Maybe it's not fancy schmancy telehealth, but it is speaking to time spent managing this patient. And I know at least one person's mind goes to how do you compensate them for that and productivity and all that other. At some point, Sherry, I hope to live long enough where we actually achieve an understanding of productive time in home health
Mhm.
and not simply make it visits. Because I think
Exactly.
that's always been part of the issue, and we have not been paid per visit in over 2 decades. We've struggled to figure out how to quantify productive time ever since then. And I've talked to
Mhm.
people way smarter than me trying to figure out how would you quantify productivity if it wasn't just about a visit? And nobody seems to be able to land on what that would look like. So we'll just call that my life goal.
Yeah, and my life goal is that every clinician will practice to the fullest, the absolute fullest extent of their license, so that you can decrease visits for unnecessary visits that could be taken care of by the clinician that's in the home. So your vision and my vision combined, Cindy, we'd have it all taken care of. Okay.
At least that.
All right, next question. During a recent audit, we were hit pretty hard about homebound status. Oh, homebound status. Any suggestions on how to help clinicians document that appropriately?
Well, you would think that all of us in home health would be experts on defining and explaining homebound status, and yet we consistently see that be a result of a third-party audit, or that homebound status is not met. I think for me, the biggest tip is to say, what specifically about this patient shows you that they're homebound? And I think what we've done is we've kind of oversimplified it with the idea that we're just going to have everybody who makes a visit to that home address homebound status, and we're going to make it super convenient by having it all be drop-down choices or boxes they can check. And all they have to do is check that box. And as long as it's done every visit, we've got it covered. That does not appear to be working. And sometimes I have to question who wrote the drop-down choices. I've seen things like patient homebound due to patient refuses to leave the home. Well, we know that that's not a homebound reason, or else we'd all do that. I'm sorry, I'm now homebound. I'm refusing to leave my house. So I'm sorry, I'm not coming to work for like the next week. It doesn't work that way. So I think to me, the recommendation has always been a combination of a checkbox. That's fine. Prompt some things, but due to a few words about fall risk, about mobility problems, and not just say they're homebound because I'm going to regurgitate the language of, taxing effort. What does that look like for this patient? Do they get short of breath? Are there issues with pain? What exactly is the problem that's limiting them from going out? And that I think would go a long way, because these check boxes in isolation of these little tiny phrases don't necessarily connect to the assessment. And so I think, especially because that admitting clinician in particular has to do this whole comprehensive assessment thing, if you're in there and, we got to deal with the 1800s and the GGs and all that, if you're identifying those kind of mobility deficits, then that right there can make your case for homebound with a quick summary of the issues you identified with that. But does it have to be dealt with on every visit by everybody? No, there is nothing in the regulation that says I am forced to address homebound status on every single visit. And I think that has also watered down the effectiveness of our documentation, because the issue is I have to do it when I establish this as meeting qualifying criteria at the beginning of care and periodically throughout. So in other words, they want us to keep an eye on not just is this person still ill or still having impairments, but do they still qualify for them to have these things come to their home? So I need to ensure that they meet that part of the criteria. The problem was with the kind of generic periodically thereafter, it got lost in translation. And then we went from you established it at the beginning to people forgot to mention it at all. So the rebound solution of we have to talk about it every visit, every discipline, I think has just caused a different version of the same problem. It's repetitive, sometimes it's conflicting. I see therapy notes that click the patient can't walk further than 10 feet and then document that the patient walked 75 feet on the visit with standby assistance. So wait a minute, that 10 feet distance has nothing to do with homebound status. So I think it's revisiting the patient specificity and how are we using the tool versus just blindly, if everybody, shoots that big shotgun at the wall and we touch on it every visit off the checkbox list, we should be fine. Because we definitely still see that third parties get in there and they're saying it's insufficient.
And just describing medically what they have to leave the home
Mhm.
for, or socially what they have to leave the home for, and really that's a great question to ask the patient and literally write their words. What happened when you got home? What happened? How did you feel walking in the front door or the garage of your house? And what did you do directly after you got back from the visit out of the home? I think that
Well-
just getting back in the habit of doing that after a doctor's visit
Correct.
or after an out of the home excursion.
Because I've been in this setting so long, Sherry. I remember when we were told, don't ever document they left the house.
Right.
I was told, don't document that you ever had them walk on grass because that meant they went outside. And I'm like, okay, so we walked on quote uneven surfaces. Grass is uneven, but that's insane. I mean, if you take them outside or they go for a hair appointment, come home, their pain is through the roof, they're short of breath, and they had a nap for 3 hours, I've just confirmed your homebound status.
Right.
I don't need to freak out you went and got a hair appointment. You couldn't just come home and continue to function. All your energy got blown on a hair appointment and now you're a mess. Documenting that kind of stuff throughout the course of care makes way more sense to support homebound than never mentioning they leave ever. And then in the final visit, patient no longer homebound. How do you even know they did it? According to this, they never left the house. So how do you know they can do it?
Cindy, I heard the words that Medicare didn't care what happened outside the home. And that literally was the statement. And then that, for me, it was an epiphany when they required the face-to-face, especially before telehealth, right? And the abilities of telehealth. Once they required the face-to-face, meaning they had to go out into the community to get the face-to-face, particularly if it was after the start of care for that 30-day period that you had, oh boy, oh howdy, am I explaining how hard it is for them to walk from a parking lot into the doctor's office, how hard it is to step up on the curb, how hard it is to stand up from a waiting room chair because they don't have their lift chair. All those things can also relate to homebound. So please reach out to us if you have any questions about homebound, because this is our next marketing opportunity. Is you can outsource your OASIS and coding with K&K and we will be your compliant solution, but you can also outsource your chart audits to K&K. Anytime you're worried about what may or may not be appearing in your charts, particularly a group of charts, and we've done audits as small as 5 charts and as large as 1,000. So having those charts on occasion audited is always a good plan to, was it a prevention every day keeps the bad people away? I'm really crazily bastardizing a statement, but wanting to let everybody know that just being prepared and staying prepared is going to save you from an audit situation that you can't get out of or that can be extrapolated. Cindy, I recently shared an article from an agency that was audited and had 100% denial. 100. And once they got that 100% denial on the records that they requested as part of the RAC audit, and it was 100% denied, guess what Medicare did?
Wanted more.
They extrapolated it and they took every bit of their revenue out. And that goes for any percentage, by the way, but this 100%, they're actually suing Medicare because I find it hard to believe that 74 charts, I think it was, were 100% erroneous. But at the same time, if they'd only found 50% were wrong, they could have extrapolated that out to 50% of the revenue. And that's scary stuff, you guys. But when we have a government right now that's looking for ways to be more efficient and to retain and get money back and back into the government, we got to be really careful how we're rolling. So sometimes the really brief audit will save you from, a stitch in time saves 9. And Cindy, did you have any comments on that before we move to the next question?
Nope, I'm all good.
Okay. So if you want to know a different way for your outsourcing and for your auditing, let us know and we can be your partner and we can make it a lot better. Okay, next question. And Cindy, it's a miracle. This is our first Oasis question.
No, we had that one that somebody typed in, so it
This
becomes
is,
our
oh,
second.
yeah, that's the second one. Oh, my bad. Thank you, Lynn, for doing that. Okay, could you provide a scenario or explanation where a patient can score a 2, someone must help, in M1810 or 1820, and then score a 6, a 06 on GG0130F, G, and H, please? Is it reasonable to believe that is supervision is necessary in 1810 or 1820? It would be the same supervision that would spill over into the GG sections.
So I would say, big picture, if because we know that in the 1800s, all of them, that all forms of assistance are rolled in together into the someone must help. So if I'm supervising, if I'm providing verbal cues, if I'm providing hands-on, it all rolls in together. With the exception of if the person can do nothing useful, then we're looking in the 1800s at the dependent response. So someone must help in 1810 upper body dressing or 1820 lower body dressing. If you're seeing a response of 2, I would not expect to see 6s saying that they're independent in upper body dressing, lower body dressing, and footwear, with a possible exception. So I'm going to say generally, if I'm seeing 2s over here and 6s and those 3 over there, I am going to dig because this at face value doesn't make sense. If you need to be at least supervised over in the 1800s, I would expect to see it. But there is a little bit of wiggle room on this one, because for upper body, no, I'd be looking at it and saying, if you say someone's helping them in 1810, I would expect to see comparable in the GGs. But for lower body, they did separate out footwear. So we know that when we're dealing with the dressing questions in the 1800s, we fall into the majority of task issue. So we have to look at it and say there's multiple elements to upper body dressing, multiple to lower. What help do they need to accomplish the majority of that? When we get over to the GGs, they put footwear into its own separate item. So that being said, if you're going to separate that out, you could see one answer in 1820 and 2 slightly different answers in the comparable GGs for lower body and footwear. Because footwear is rolled into 1820, it's separated out in the GGs. So it could happen that maybe for the majority of lower body dressing minus the footwear, they need help, but somehow they can do their shoes differently. I'm not deliberately slowing my roll of my voice. I find it highly unlikely, but I am never going to sit here and say that could never happen, or you always have to have the same answers in GG. Because CMS doesn't say that, I'm not going to say it. I follow the rules, don't necessarily like them all, but I'm going to follow the rules. But realistically, we should see a harmony between these. And then looking at it to say, okay, so what is the difference here? Because someone must help being supervision. Yes, I would expect supervision looking in the GG. But as we touched on earlier, if it's more than that, if we're getting into minimal assistance, moderate assistance, then that could change answers that we're seeing over in the GGs, because it does let us separate out less than 50% and more than 50%. So when I always try to stress, any of the 1800s against the GGs are not necessarily an automatic identical match, because there also should be, but there should be some degree of harmony. The other one that's a good example is 1800, because grooming is way more comprehensive in the 1800s. When you get over to the GGs, it simply talks about oral hygiene. So that one again could read different, but anytime, I'm just gonna, my own personal thing, anytime I see help is needed in the 1800s and a 6 dropped over in the GGs, I am gonna question it. because yes, there's some nuances. Yes, there's some situations where it could work, but it tends to, in my experience and in talking to our review team, the 6 is not accurate. They're not needing help over here and then miraculously fully safe and able in the GG version. Sherry, I think your mute's still on.
Okay, just wanted to let y'all know that was our last question, and I wanted to tell you guys that we do record this, so if you have to run, since we got a little bit of a late start, we're ending with a fun question though. Cindy, what is your favorite question, Oasis question, and why? And those of you that are still on, please add yours in the chat, because we'd love to know what your favorite Oasis question is. And I fully expect that somebody might tip in who is the crazy person that has a favorite Oasis question. Cindy, but go ahead with yours.
Wow. Okay. Well, it can vary. I can vary what mood I'm in, I guess. And you're right. The fact that I have one or a few might need to look up and see if all those coding changes coming next week, October 1, might include some sort of capture for Oasis Obsession. I think the one I like as far as illustrating both the importance and some of the lunacy of Oasis data is item 1850 for transfers. I think because it reads, I'm going from a bed to a chair, blah, blah, blah. And
I knew it was going to be a functional item.
Well, but that one in particular, because I just keep calling it when I teach the get up and go find a chair transfer. Because when you talk bed to chair, especially as a therapist, you immediately have a visual, and that could be what it is, but it could also be getting up from the bed and going to the nearest seating surface, which could be the bathroom. It could be the toilet in the bathroom. It could be a chair in the other side of the room. And that's where you kind of go, mind blown that that's not a bed to chair transfer, but it is in Oasis. It's not as a therapist. And it's also a great one in terms of pulling apart those response options, in terms of needing someone or something versus someone and something. And then you get into responses that talk about unable to transfer self, and people just lose it because it's like, that's ridiculous. So you're telling me somebody who needs to use a cane and supervision to get from the bed to the bathroom and back, because that's the nearest seating surface, is unable to transfer self? Well, in non-clinical language, that's true. They're not. They're using a piece of equipment and they need the presence of a human being in order to complete that task safely. I think we immediately go to unable to transfer self is deadlift. Unable to transfer self is I'm pulling this over and all this. So there's so many pieces to pull apart in that question. But once you understand that, I think it sets the stage for, you know what? I didn't write the question. I didn't write the response options. As the data collector, I want to know what the directions are, and I'm going to follow the directions guilt-free because I think it's weird, and I think that makes no sense whatsoever to my clinical brain. But oh well, I need to answer the question, and I want to make sure that I am following the instructions. And I like the folks that are chiming in with none of them. I don't like any of them. So maybe I'm the only one who suffers from that. But I think there are, a few that can really be ones to focus on, to acknowledge some of this is crazy, right? It's just crazy. Oh,
Roberta put a nice one. My favorite Oasis question is review is M2401 because it absolutely requires the clinician had reviewed about 6 areas of previous documentation by themselves or others, and so often they cannot. They think they can magically pull this info out of their brain. Not.
Yeah, 2401 is definitely interesting in terms of how well are we documenting forward, knowing that ultimately the last one in is going to have to deal with this, and do I have a team mentality of I took care of this part. Where can we put this in the documentation to tee up the discharge person for a one-stop shop to look for these 6 areas versus, and I think there's some selfish motivation in that because there's a good chance at some point I'm going to end up the last one in. And
Yep.
no, I don't want to read every visit from everybody to see if anybody figured this out, or choose to only answer it for myself. And no, I didn't do that. And no, I didn't do the other. Well, somebody else did, and you should know about that before you discharge them. So I think that's a great one, Roberta, for how well are we coordinating this care? In terms of if I took care of that on the third visit, is there a place in the EMR I could just cut and paste and drop that? So by the time the person who gets to the discharge has to deal with it, they can go look at it and say, yep, that got taken care of, that got taken care of, and that got taken
Yep.
care of. And I only had to look at one spot.
That's a great thing to ask your EMR provider too, if they could provide that link and have it go through to that question. Cindy,
But
I'm
worst
surprised
case,
you didn't
Sherry,
say
you could even
anything.
make it a communication note.
Oh, yeah.
You can rig it up and say, if you took care of one of these things on your visit, just drop a little thing over here. Bill, you did this. That way, whoever gets the discharge can just go look and doesn't have to either be psychic or read every visit note, which we know is not going to happen.
Love that. And we have I'm surprised you didn't say anything about my picture this month. And my picture is a porch front that's full of mums. And I live in Florida, and Florida is where mums come to die. Cindy, are you able to do mums in Atlanta or outside of Atlanta?
Well, when I first moved here 6 years ago, I thought I could, and then they all died. I don't even know why they sell them here, because what I have transitioned to, and I will just confess for our audience today, this year, they're fake. I got a couple because I like the look and they're nice fake, not super plasticky fake, but I'm like, that is it. I am tired of buying them and watch them burn to death. I'm going with this.
Well, I live with the Yankee, and it seems that a mum shows up on the doorstep every year, and it's just a countdown till until it's just going to be a big stick farm. So those of you that are living in the north can enjoy these beautiful decorations on your porch, but just feel for us Southern people. But I guess you probably won't feel for us Southern people because it's 70 in January. But just feel for us that we can't enjoy the beauty of mums during this time of year. Okay, so final things. Our next session of this will be November 20th. And don't freak out because, believe it or not, Thanksgiving is not until November 27th this year. So we'll see everyone on the 20th at between 1 and 2, and look for the recording in your inbox. Cindy, any final thoughts before we go?
No, thank you everybody for participating with us, and keep sending those questions in. If you have an urgent question, we are happy to answer it for you directly and also add it to the list for the next session. So we are happy to help in any way we can.
Thanks, everyone, and be safe out there.
Have a great one.